Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Adelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board certified pediatrician, and international board certified lactation consultant. I care for breastfeeding diets and private practice in the outpatient setting.
Hi, Lena, how are you?
I'm doing well, Anne. How are you today?
Good, good. So today I want to talk about I'm going to talk about steroids in milk and infant behavior. And this is a study that is entitled Moment to Moment Bidirectional Associations Between Human Milk Glucocorticoids and Infant Behavior. I'm not going to use the term glucocorticoids so much because mostly what we're talking about is cortisol and cortisone, but I'm just going to sort of simply say cortisol because it's kind of a term that everyone knows. And the first author of the study is Bruinhof, Bruinhof, and their colleagues. And this is a study that was done in the Netherlands. And this was published online February 17th of this year. So this is a study that wanted to look at whether maternal stress would have an impact on hormonal changes in milk, which would then impact infant behavior. So being in this field for a long time, I remember reading articles, back from like the 1800s, early 1900s, even like 1920s, 1940s, when when breastfeeding sort of fell out of favor. And one of the reasons that sort of people use to justify why artificial feeding may be better is that women who were undergoing like mental health issues, that their milk would probably maybe poison or be toxic to babies and maybe affect their behavior as well because of like the what is the term that they would use? Like humoral substances in their body would go into the milk and then like affect the baby.
Ah, okay.
So, but but then some articles started coming out saying, well, yeah, cortisol levels in milk do change according to stress. And then people started thinking, well, gosh, maybe that's right. Maybe milk does affect infant behavior. So we know that cortisol levels increase when we're stressed out. So that's, of course, that's one of the ways that we test for stress, right? That's one of our physiological markers for stress. And there is some evidence that cortisol levels, they reflect the maternal plasma. So when cortisol levels rise in the maternal plasma, it'll rise in breast milk as well. And so the question is whether cortisol changes due to stress immediately impact cortisol levels in breast milk and then also have an immediate effect on infant behavior. So the authors in this article, they bring up this process that's called lactocrine programming, which I've not heard before. And I feel like I want to take a deep dive into that and see what they're talking about.
Yeah.
Unless they made it up themselves, I don't know. But the term lactocrine obviously comes from lacto and crine, so lacto, milk, and crine meaning endocrine or hormone. And the idea is that natural steroids in breast milk may have a long-term impact on infant development. And there have been studies that, as I mentioned, that cortisol concentration in breast milk correlates with a level in maternal plasma. And it does vary according to either acute stress, just a general sense or general experience of psychological ongoing stress. And even people who have experienced adverse childhood experiences, they also have higher baseline cortisol levels.
So were they, just to clarify that, were they looking at stress as more emotional feeling stressors, or were they looking at stressors like parents with significant medical illness, like a more physical stress?
Yeah, so I think that I don't know, because they just describe, the fact that there is this evidence that that having higher cortisol can lead to higher cortisol in milk. And cortisol will go up from all kinds of different stress, whether it's medical, whether it's, car accident, whether it's, psychological stress. But they just looked at so we'll talk about the study in a moment, but this is just kind
Sure,
of
sure.
this is kind of sort of background. Um, and what's interesting is that there's evidence. So you think about, okay, if there's cortisol in milk, is the baby even absorbing that, right? Because it's a hormone, and we know that hormones, are hard to absorb, and that's why the GLP-1s are shots, and that's why insulin is a shot. Because when you take it orally, it may not get absorbed well. But there are animal studies that show that glucocorticoids, cortisol in milk can actually cross the gut and enter the baby's circulation and actually get into the baby's brain and therefore affect infant brain development and infant behavior. And that's, I think, one of the
Mhm.
reasons why this is so interesting to people. So, according to the authors so far, studies that are done trying to link milk cortisol to infant behavior have been mixed. And many of the studies have focused on the relationship between just like one cortisol sample, milk sample, um, and infant behavior. But this is hard to correlate because milk cortisol has circadian rhythms, right? So it's higher in some parts of the day than others. And there's only been one study so far that collected multiple milk samples throughout the day, and they didn't find any relationship between the cortisol level and infant sleep behavior at 3 months postpartum. And so they just looked at sleep. The other thing that the authors, before we get into exactly what they did, they talk about this whole concept of reverse causality. So if you're going to look at, so for example, a crying infant, so a baby cries, can cause the cortisol level to go up in the milk, right? Because the mother's all stressed out. So the milk cortisol level goes up. And so it's a chicken and egg thing, like which is causing what, right? So is the
Mhm.
cortisol causing the baby to cry, or is the crying causing the higher cortisol? So that has to always be well controlled in these studies. So the authors in this study, they wanted to sort of include that to make sure that they were not dealing with reverse causality, which I appreciated. And they wanted like to capture short-term fluctuations in milk cortisol throughout the day, and then correlate that with infant behavior. So they had some hypotheses. They thought that a higher milk cortisol concentration would cause more infant crying and less sleep. That the infant would like get charged by that and then like get a little bit wigged out. And then they also thought that if the infant was crying and wasn't sleeping well, and then, for like an hour and a half before collecting that milk sample, that milk sample would have higher cortisol because the mom got stressed. So that's kind of what they were looking at. So they collected this data from a longitudinal cohort it was called the Study of Microbiota and Lifestyle in the Early Years. So this is a Dutch study done in the Netherlands, and it was this it's a cohort of 160 healthy women and their infants who were recruited at around 18 weeks of pregnancy, and they were followed for 2 years, and they were collecting a whole bunch of data. And this is just one data set. And these are families who were generally healthy. The babies were born after 37 weeks, and they were healthy too. And so what they had the mothers do is collect milk samples and also record behavioral data on just a normal day at home. They didn't want them to be in any kind of lab or anything like that. And they did this at around 6 weeks postpartum. And the milk samples were collected in three predetermined time windows. So they collected milk samples between 7 and 10 a.m., 11 to 2 p.m., and then between 7 and 11 p.m. And what's interesting is that they only wanted 4 ml, which I'm like, 4 ml, that's going to be 4 milk. But they intentionally said, yes, we wanted 4 milk, which I thought was
Wow.
interesting. So I wonder if there's just more cortisol in 4 milk. I don't know.
And with the time frame, was there any guidance into that? Like we want you to express milk at a time that your baby is about to feed or before feed, after
I
a
think it was
feed
right before.
happens.
I think it was right before feed. Yeah, yeah, it was before feed. Yeah. So on the same day they completed a standardized on the same day that they did these milk samples, they did the standardized diary, and they were instructed to record their infant's behavior as often as they could, with a minimum of every 2 to 3 hours, but as often as possible. And so they had to categorize their infant behavior as either sleeping, awake and quiet, fussy, crying, which I don't know the difference between those two. It's like a fine line, right? Feeding is another category, and then there's a category called unknown. So what they found is that, as expected, the milk cortisol and cortisone levels had this circadian rhythm with higher concentrations in the morning and lower concentrations in the evening. So that makes sense. And then they also found, which was interesting, they didn't confirm their hypotheses. They found that when there was a higher amount of cortisol and cortisone in the milk, that the baby actually slept more for at least an hour and a half after they breastfed. So if the milk levels were higher, and then they looked at the infant behavior, like right after they fed at that higher with that higher cortisol, those babies slept longer. The higher the amount, the more they slept. Like there was a direct correlation there.
Oh,
Yeah. Um, and yeah, so they found that the more that more there was more infant sleep during that time um, according to that cortisol level. And then there were more infant sleep during the hour and a half before feeding, um, was related to actually higher milk cortisol and cortisone levels. So if the baby was really quietly sleeping, minding their own business, like being babies, quiet babies, for a good hour and a half before the mom took a milk sample because they was going to wake up and feed, that cortisol level was higher, and you'd think, and they expected it to be lower. They thought, oh, the baby's sleeping, mom's less stressed, cortisol is going to be lower. Well, it was actually higher. So that really surprised them too. And they didn't find any relationship between milk cortisol levels and infant crying, meaning that if the infant was crying for an hour and a half before they collected that milk sample, the cortisol level was not high necessarily. And if the cortisol level was high at the time that the baby fed, that hour and a half later, they were more likely to be sleeping than to be crying. Whereas they thought, oh, wait, this baby's going to get a bunch of cortisol. The baby's going to get like stimulated and charged, and it's going to go to their brain and make them be like, and it didn't do that at all. It made them sleep.
mm,
So, um, so the only way they could really explain this behavior, that they could explain this, is that they gave this analogy of like when an infant undergoes a painful procedure, like a circumcision. You circumcise them, and then they just like sleep, right? They just check out. They just went through a really, you have something really stressful happen. Like sometimes I've had, you've probably had this as a pediatrician. Someone brings their child in because their child fell on the playground and they're worried about their child. And the child comes in and you say, what was the child's behavior after you picked them up from school? And they said, oh, they just fell asleep in the car. You've probably heard that story. Or they fell asleep, they took a
like
long,
very quiet, very withdrawn, just
yeah,
not
just checking out. Yeah,
ex
right. And so they said that this is that maybe when they're getting that high amount of cortisol in the milk, that maybe it's like they're experiencing this stressful situation and then they just check out for a period of time. The other explanation that they give for this is an adaptive response. And so if there's a higher cortisol level in milk, that maybe that makes the baby sort of play possum, so to speak, so that if, like, let's say you have, a mother and a baby who's hiding in the woods from, a predator, and the mom puts the baby to the breast just to quiet the baby, and the baby gets this cortisol, maybe they'll just like shut down and not cry because the crying would attract the predator, right? And
Mhm.
so it's like, yeah, so playing possum. So I thought that was, I mean, you gotta kind of figure it out, come up with some reasoning for why you have the results that you do, but they were pretty interesting.
Yeah.
And then the other thing was that the higher cortisol level in the breast milk when the baby was sleeping, then they were like, well, how did that happen? So they thought, well, maybe these moms, when the baby was sleeping, these moms were like working really hard to get like all the tasks done in 5 minutes, which that's one thing I learned as a new mother. Like, man, the number of things I can get done in 5 minutes is unbelievable. And you're working really
So the
hard.
parents were actually revving up their own cortisol by trying to get things done, even though the baby was giving them a peaceful environment. They were creating
Right. Because the baby doesn't sleep that
their own
much.
chaos.
Right. Like how many mothers are like, oh, my baby's sleeping. I'm gonna go like take a bath, or I mean, they should, right? But they don't. And so, yeah, or they're on social media and they're all stressed out from social media or something like that. Um, so yeah, so that's kind of what they found. And I think the important final message here is that maternal stress can raise milk cortisol, but it's not necessarily going to have a negative effect on the baby. I think that when we talk about like infant development and the setting of a mother who's like super stressed out or really depressed, it probably has more to do with the interaction with that baby, more so than like the hormones that are happening in breast milk.
Like the milk itself contaminating or
Yeah.
being contaminated or hurting the child. And
Yeah.
um, when you were talking about this, it makes me think of, I think it was during one of our, I forget which IABLE presentation it was at, but we had a doctor who was talking about a lot of women in her community after a hurricane not wanting to give bad milk to their babies due to the stress that they were feeling and giving them that reassurance that they're not transmitting badness like the bad humors like you were saying through the milk. She had a specific term for it in Spanish, but I can't remember what that term was. But
Yeah.
those thoughts
Yeah.
exist everywhere,
Yeah. No, I do.
very
I still,
pervasive.
yeah, I hear that occasionally from patients. They'll say, well, I really don't want my stress to go through my breast milk. And so I think it makes sense that, if there's stress, it does really make sense that if there's stress, we don't want it doesn't make sense that if the mother's stressed, right, and her cortisol goes up in her milk, that would lead the baby to cry more because there's no evolutionary advantage to that, right? For the baby to cry more. If anything, it would calm the baby so then the mother can maybe, okay, my baby's calm, maybe this will help calm me. I can hold my baby, I can have
Mhm.
skin to skin and oxytocin. And maybe that's so, you think about it, like, gosh, maybe that is like a therapeutic thing for the mother, really. Because, holding a baby and skin to skin is one of the best things in life, right? So
For all parties involved.
for all parties involved, yeah, yeah, yeah. Interesting.
Yeah.
And I'm gonna look up this lactocrine field of whoever started that, and kind of maybe we can do something or another about that. So some
Yeah. And also the study only looked at one hormone. Like we can't attribute all infant behavior just to cortisol. It's cortisol's interaction with all the other hormonal pathways, and endocrinology is so complex and all these
yeah,
positive and feedbacks, and sometimes your positive feedback's actually overwhelmed by a negative feedback. And if you don't know which pathway to look at and you're looking at one isolated pathway, you're just gonna miss the full story.
good point. Yeah, great point.
All right. So I've got an article for us to talk about today too.
Sounds good.
Um, so this article, it was e-published ahead of print, but it should be coming out in the February issue of Breastfeeding Medicine. It's evaluation of the safety of taking Brexiprazole during the lactation period. And it was by Akari Fukuda, and a whole bunch of other authors. So Brexiprazole, brand name, it's available. It's called Rexulti. It's an antipsychotic medication that was introduced in 2018, and it's considered to be an atypical antipsychotic, and it's used to treat schizophrenia and major depressive disorder. It was actually first introduced more for its antipsychotic purposes and then approved for broader use. And it's in the same class of medication as aripiprazole. Brand name is Abilify. Whenever new variations of medications in the same class come out, I'm always like, well, why? Like, if you have something that's working and it's working well, why are you going to want to modify it? Like, what's the benefit of this new one over the other one, other than a couple of letter changes? So, brexiprazole has a similar effect to aripiprazole in reducing psychotic symptoms, and it has a similar rate of metabolic adverse effects. And aripiprazole, it acts through 5-HT antagonism, 5-HT agonism, and alpha 1B antagonism. So a lot of different, these are mostly serotonin receptors to mitigate extrapyramidal side effects. Um, so Brexiprazole, the reason why it acts differently than aripiprazole, it has greater potency at each of these three receptors. So its greater potency for the 5-HT receptors, it could represent it having greater effectiveness for treating specifically depressive symptoms. Brexiprazole has reduced antihistaminogenic properties, and it therefore leading to less sedation, less somnolence, and that could improve positive and cognitive symptoms in a patient. So the purpose of this study, it was to evaluate the safety of brexiprazole during lactation as a newer medication. The studies on this are very limited. And the two main effects they were looking at, the side effects in the breastfed infants, and also they did note effects on milk production. Um, the authors, they did point out that the general principles regarding management of mental health, and um, many, all physicians agree with this, whether it's schizophrenia, bipolar disorder, depression, management during pregnancy and lactation, we really need to consider the risk, or really the risk-risk ratio of continuing medications in terms of managing symptoms versus the risk to the child of being exposed to these medications, and then the risk to the child if a parent is not being adequately treated. So, antipsychotic drugs that contribute to mental stability, if a mother is really doing well during pregnancy and lactation, they should not be easily replaced with other medications. So, more about brexiprazole. We talked about the receptors that it affects. It also affects, there's some partial stimulation of dopamine D2 receptors. The dose of that's usually prescribed is 1 to 2 milligrams a day for adults. And of note, it has a very long half-life, 91 hours.
Hmm.
So the drug databases out there, as of now, there's really not enough studies out there that say one way or another that this medication should be considered safe during lactation. And they throw away that lovely phrase, consider alternative drugs, more so just because with other medications, there's more information available. So this study, it came out of Tohoku University Hospital, which actually had a unique system in place even before the study took off, for capturing women with mental health conditions and helping them come up with like a good shared decision feeding plan.
Where is that
So
located?
at
Where is that?
Tohoku University Hospital,
And where is that in the United States or?
Sendai, Japan.
Oh,
I think it's,
Japan.
yeah, Sendai.
Okay.
So at this hospital, at 20 weeks gestation, pregnant women would fill out a check sheet form, and they would list their disease symptoms, the medications they were using, the dosages, and take note of their desire to breastfeed after delivery. And these forms, they call them plan sheets for lactation. Based on these check sheets, the midwives would interview each pregnant woman about her background, note any of her concerns about breastfeeding after delivery, um, and send these forms and their notes to the Department of Pharmaceutical Sciences, where pharmacists would collect all the information available about the medications these patients were on. Um, Reference reliable sources, provide those citations along with the pharmacist comments to the obstetrical team. The obstetricians would discuss with the pediatricians who would be taking care of the babies once they were born, about any potential risk to the breastfeeding infant whose mothers were taking these drugs. And then this information with input from pharmacists, the OB team, the pediatricians, would be presented to the pregnant patients for a shared decision-making conversation. So this system was already established for all patients, and they were able to identify patients who were taking brexiprazole through this existing system. So the pregnant women who were taking brexiprazole, they were identified between 2018 and 2023. The authors identified 7 dyads who filled out these plan sheets for lactation and who were taking brexiprazole. They did have to exclude some of the dyads because 3 of the mothers switched from brexiprazole to another psychotropic agent after delivery. And they excluded a mother and a dyad because the mother chose to exclusively formula feed, so that really wouldn't contribute to the study. So the remaining 3 dyads were included. So this is really just like case reports. It's not a randomized controlled trial by any means or a cohort study. But these case presentations, they're good because if you see anything outline that's sticking out, it gives you information for what you may want to look for in a broader study.
Yes. Yeah.
Okay, so they collected information regarding specific maternal characteristics, maternal age, her body mass index pre-pregnancy, the daily brexiprazole dose, why she was taking brexiprazole, like the underlying disease pathology, um, and how the age of delivery. Infant characteristics included infant sex, the baby's birth weight, the birth weight and the weight at the 1 month checkup, weight gain, how the baby was being fed, whether it was exclusively breastfeeding or mixed feeding. They looked for neonatal withdrawal symptoms, if there were any adverse events to the infant in that first month of life. And all this information was collected retrospectively from the medical records. So I'm going to go through each of the cases individually, and then we could summarize what their takeaways were. So the first patient was a 32-year-old BMI of 22.3 who was diagnosed with depression at 16 years of age. She was taking brexiprazole 1 milligram a day starting at 29 years of age, discontinued at 31 years of age. So it was on it for a while, discontinued 1 month before conceiving. But then while she was pregnant, the brexiprazole was restarted at 28 weeks gestation. They didn't say why they started it at 28 weeks, but did take note of that pause in between. The brexiprazole was continued for the rest of pregnancy and for lactation. She gave birth to a healthy, normal birth weight female at 40 weeks with solid APGARs 8-9. No adverse events were noted. The infant had no withdrawal symptoms. At the check-in on day 16, the baby was being supplemented, so it was receiving 30 to 40 mLs per feed 2 to 3 times a day of express breast milk. However, the rest of the feeds were formula, and by the 1 month visit, the baby was receiving 10 to 40 mLs of expressed milk 1 to 3 times a day, the rest being formula. The second case, it was a 41-year-old who had a BMI of 21.5. She had a diagnosis of schizophrenia at 19 years of age. Treatment with brexiprazole was initiated at 39 years of age at 2 milligrams per day, continued for pregnancy and lactation. She delivered a baby at 39 weeks, solid APGARs 8-9 again. This baby, though, did have a cleft palate. Similarly, though, did not have any withdrawal symptoms. And this baby did go to the NICU for some jaundice and for management of like initial feeding with the cleft palate. At 19 days of age, the baby was receiving a combination of breast milk and formula. This was a little bit confusing for me to understand. I think there may maybe it was either misreported by the parent or in the article, but it says the baby was getting 100 mLs of breast milk for 8 feeds, but also was getting 100 mLs for 8 feeds of formula. But a baby taking 1,600 mLs in a day is a lot of intake. So
Yeah.
probably the baby was getting 100 mLs per feed, and it was some variation of that, some combination of that. At the 1 month visit, the baby was receiving 100 mLs of breast milk once a day and 120 to 130 mLs of formula for 8 feeds a day.
So really low
And
production,
this baby,
probably.
because of the cleft palate, was it was all pumped. It was all
Yeah.
pumped milk
But
or formula by
was there
bottle.
any discussion in these first two cases about the level of lactation support, frequency of pumping, like any details about intensity of lactation? Because I find that a lot of times, people don't know what they're, if they don't know what to do. If they don't have much milk, then they kind of like are like, well, I don't have much milk. I'll just give some bottles and maybe I'll wait for more milk. Like they don't, they're like
Right.
in this,
Or with
yeah,
some of these medical conditions, is continuous sleep important for them in terms of mental health stability? Like, were they
right.
doing routine milk removals overnight, or were they prioritizing sleep? Those are all really good questions that were not brought up.
I mean, if we're going to look at
Um,
like if we're going to look at the effect on lactation, we want to know secretory activation, we want to know level of support, we want to know frequency of pumping, like we need to know all that stuff. It's kind of
all that
sad.
would have been good information to have to see. Yeah, because right now, well, for the third case, I'll just go through that one and then we could talk more about limitations of the study and what was able to be gleaned from this.
Mhm.
It was a 34-year-old, BMI 17.7, also had a diagnosis of schizophrenia. Diagnosis was made at 15 years of age. She was on Brexiprazole since 3 years prior to conception, maintained throughout pregnancy and lactation, and gave birth at 39 weeks. This baby had a relatively low birth weight, but good APGARs, no adverse events, no withdrawal symptoms noted. But again, did require supplementation at 19 days of life, was receiving breast milk and formula 6 to 8 times a day, was receiving some pumped breast milk, but the amount was unknown. And the amount of formula received was still 6 to 8 times a day. So was getting 60 to 100 mLs of formula with every single feed. Um, so like you were saying, we don't, if we could talk about the impact on lactation, on milk production first. Um, we don't have any information about when secretory activation happened. Was milk, was lactation support adequate for what we would need to have a mother receive to build milk production appropriately. Um, but it's clear that all these babies did need to be supplemented significantly and that production was low, but we don't know why.
So can I just ask, like, in the background of the of this paper, did they say what was their intention to look for infant outcomes in terms of like, because it sounds like they're recording all this behavior, withdrawal side effects, all this stuff. Was it more like looking at the outcomes in terms of like the intrapartum outcomes for the baby, APGAR scores, infant behavior, ability to feed, blah blah blah? Or was it more like let's look at the actual impact on lactation, or just not really committing to anything necessarily and saying let's just see what happens? What were they really looking for? Because it doesn't sound like they did either of them really intensively.
Yeah, I think it was more the latter. I think it was more the latter and just seeing what information they could get because there was so little out there on Brexiprazole. Um, the they wanted to see if there were any signs of withdrawal in the baby or if the babies had any specific adverse events related to receiving breast milk with Brexiprazole in it. Um, And they did take note that there was mild cases of infant jaundice and acne in all three of these newborns, but on the spectrum of what typical newborns have, and they consider that to be unrelated to the Brexiprazole exposure. And their takeaway was that they did not identify negative symptoms in these babies. Um, my takeaway is I don't know how much milk these babies were getting to
Right.
have
Right.
a significant exposure.
Right. Yeah,
But
probably not
they
much.
do, yeah, not much. And they do explore the properties of Brexiprazole. So it does have a molecular weight of 434 Daltons, but it's highly protein bound, 99.8%. So that the high protein binding, it really makes it unlikely to transfer significantly into breast milk. Um, and in addition to the low milk production aspect of this, they do know the limitation is that they did not measure blood concentrations of the brexiprazole in the newborns, because that's a pretty invasive
That's hard
thing
to do.
to
Yeah.
check blood levels on a baby, unless they were getting blood work for some other reason. But just for this alone, that'd be a little unethical. Um, and you asked about like outcomes also, like during due to exposure during pregnancy. One of the babies did have a cleft palate, but that's one of the more common congenital abnormalities. And they did dig a little bit deeper into animal studies on this medication, and in at least in animal studies, they didn't come across any reports of congenital abnormalities associated with brexiprazole administration in animal studies during pregnancy.
Yeah. I think
Um,
this kind of goes to, I mean, so, the question is, it sounds like this is a retrospective, like chart review or something rather than like an actual cohort where they actually follow these people. And that's, yeah. So when they're just doing that, then, I mean, either way, like if you're going to dig into the medical literature or dig into chart reviews, right, it's still having someone who's a breastfeeding specialist to look at that and to make comments about, look at all the fine details of anything that the patient reported to the nurse about, like, oh, my breasts don't feel full or something like that. I mean, they would have picked up on that. But I feel like so many studies, when they say, let's find out about lactation, they don't bring on people who know about lactation, who can actually enrich the story and the data that they're sharing. It's such a
mhm.
problem. Yeah.
Yeah, yes, it would be, and perhaps this does happen during that shared decision-making conversation after they fill out their lactation plan sheets, but they didn't specifically include in it that there was a lactation consultant or a breastfeeding medicine specific person who took part in this conversation to say, we're talking about these medications and the potential impact on your baby, the potential impact on your milk production. But let's give you the education on how the physiology of lactation and how it works. So we set you up to have the best start, and then we see what happens.
Hmm.
Um, that step wasn't
Yeah.
necessarily
Yeah.
highlighted.
Well, I think the bottom line is that, we're all suspicious that this is going to be similar to aripiprazole, right? I mean, aripiprazole, we have had many cases of this, of people taking it during their pregnancy. We don't really know to what degree it's impacting breast development, but it's pretty common to see very, very low milk production and often no milk production whatsoever until they stop
Mhm.
it, if they can stop it, depending if if it's appropriate for them to stop it. And then it takes another 2 weeks to get their production up. And for some people, they've been absolutely thrilled to stop it because they felt like it wasn't doing anything for them anyway. And they got their production back and everything worked out well, that they saw the right person who could actually help to coordinate all that. Um, but I think that for
And the
now,
half-life of brexiprazole is longer than the half-life of aripiprazole.
yeah, that's what you shared. Yeah, which is really scary. And so there is a rise of reproductive psychiatry. And I think that among physicians who do have gained more education in that space, particularly those who do identify as specialized in reproductive psychiatry, they're aware of this. And I think two things. Number one is being aware of the effect of this medication. right, on lactation. And number two, caring about lactation, right? Like people who prescribe don't always, they may say, well, mental health is number one. Like, let's not worry about lactation. Like, we need to save your mental health. Well, breastfeeding is part of mental health, right? And so it can't be the prescriber who makes that decision. It's got to be the patient who makes that decision, right? And it's one of those other things that keeps me in this field, right? That just the injustice, to lactating families, that they deserve to have control over this and be able to lactate if they, to have the right to lactate, and not have it be
Yeah.
something that the doctor doesn't know about, giving them a medication and then not having any informed consent that this is what can happen. So,
And it doesn't need to be to make them wary of taking a medication per se. Like it's a similar conversation that women who have breast reductions, which are quality of life improving
yeah,
procedures that do impact lactation. It's a discussion that they have as well. And many of women still go forward with this thing that they know a procedure that they know could impact lactation, but improves their quality of life. That when it comes to mental health, you could have a very similar conversations. Like this
yeah,
could really improve your quality of life, but you deserve to know these things. And
right. Right.
yeah.
Oh, I've had patients like I had one patient who was on 10 milligrams of aripiprazole. This was a number of years ago, and they had no milk. They took it for many years and had treatment-resistant depression. And this was what really got them through. Like this was the key to keeping them out of severe depression. And so got pregnant, had no idea that it was impacting lactation. This is before we even talked much about it. So this is a while ago when it was earlier on the market or something. And she had no milk, and I explained the situation. And she said, I'm sad that my psychiatrist didn't tell me this, but there's no way on earth that I would ever not be on this. And I have to be on this medication and in order to take care of my family. And so, yeah, we have to recognize too that for some people, they know that this is what's needed for them. So, yeah. Well, thanks for sharing that. I think I do think that we need to, would you agree, just based on what you read, that we need to just be cautious with this medication for
Oh, yes.
lactation?
And
Yeah,
and or if a patient is taking it, giving them just so that awareness that they're based on its mechanism of action and what we know, it's reasonable to anticipate that it will impact their milk production. Now, if I had a patient who was on it and who was producing some milk, um, I think it's reassuring knowing that that milk was not causing any adverse effects in their baby, that they that I would encourage them to still give that milk to their baby.
yeah,
Like if I was meeting them on the flip side of it.
yeah, yeah. Great. All right. Well, thanks. That was a great conversation. And we'll talk to you again in a month.
All right, talk to you then, Anne.
Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org. So come check us out and become a member to join our community.